a wire into the branch initially.
Yeah, but maybe it's rarely used, only in case with lower backup or unstable guiding position. So,
just one other question. Obviously, there's this progression of wires from the XT, which is the starting, or FC, and then onto the Miracle 3 or Ultimate, as you've told us. The interesting thing is that I've noticed that very few Japanese operators will progress from a Miracle 3 to a Miracle 6 to they often will jump from the Miracle 3 to the Conquest.
Conquest or Miracle 12.
Maybe would you like to comment on that?
Just to save procedure time. And so I cannot recommend jump up for CTO beginner. Probably, especially in the long CTO region. So as already we discussed, in the long CTO region, most important issue in the Antegrade manner is to explore the true channel using a tactile feedback. So in those cases, step-up selection is still important.
I'm interested to know about how you select guides. And many of us use, or many people often utilize fairly aggressive guides like Amplatz left catheters, for example, for the right coronary artery. Having seen you work, I know that you're not very keen on using Amplatz left guides. Can you tell us how you decide which guide to select to start off?
Yes, of course, backup is very important. However, usually it's very difficult to make a coaxial formation with Amplatz left for right coronary system. So in those cases, sometimes chip of Amplatz caster create ostial damage. So I only use Amplatz guide for right coronary in case with widely open ostial RCA enough to advance Amplatz deeply. So in those cases, provide a good support and no dangers. However, usually Amplatz left, I believe it's dangerous, especially with no side hole cast.
I've heard your comment before about the use of contrast injections down the microcatheter to confirm the true lumen position of your wire, and I know you're not a big fan. You don't like that. Can you explain about that again?
Probably, of course, you can do that safely before wire manipulation. But once you create some space inside the occlusion, sometimes Antegrade injection through microcaster create dissected space automatically. So just I can recommend you can use a chip injection in the Antegrade manner before wiring inside the CTO, right?
But once the wire is through and you're not certain whether you're in the true lumen or not, and the wire is distal, and you get your microcatheter down there, you don't like injection.
I never do that.
Yeah,
I don't like it.
Could you comment just quickly again on the use of side holes? It's not for perfusion of the vessel. It's more for not creating a pressurized injection into the vessel. Is that correct?
Yeah. So if you use guiding without side hole, sometimes it stuck in ostial, and injection cause damage, and we cannot clearly see blood pressure. So of course, to save a contrast is also important. However, now we rarely use a big amount of contrast because of we can use parallel wiring, IVAS guidance, or retrograde approach. So now we don't need contrast, right?
All right, we'll make this the last question.
So
When you use the anchoring balloon technique, what size balloon do you choose and how high the pressure do you go?
Yeah, just I can recommend a bigger balloon, but very low pressure, like 2 or 3 atmosphere.
So for atrial branch, you use a 2.0, for atrial, small atrial branch?
Small atrial branch. Yeah,
proximal,
yes,
right?
yes, yes.
2.0?
Balloon size, yeah, depends on size, but usually 2 or 2.5 with low pressure, yeah.
All right, well, I'll draw the session to close. I'd like to thank all the speakers. It's been a great session.
Thank you.